Change your death, change your life. Change your death, change your life. I expect that this title sounds somewhat counterintuitive and perhaps even nonsensical to many of you. But by the end of this presentation, I expect that this title and this statement will not only make more sense, but will become obviously and perhaps inevitably true. By thinking thoughtfully about death and end of life, you can change your life for the better. I'm a physician. I'm a specialist. I specialize in two different fields of medicine. One is hospice care, and the other is palliative medicine. Hospice care is medical care for patients with a life-limiting illness. Hospice care is considered to be the model for high-quality, compassionate care, providing expert medical care, symptom management, emotional and spiritual support tailored to the patient's needs and wishes. It also provides support to the caregivers and families of these patients. And the care with hospice care focuses on optimizing quality of life rather than curative or life-prolonging treatment. Palliative care is different. Palliative care is a medical subspecialty, much like cardiology or oncology or neurology are medical subspecialties. Cardiologists focus on treating and managing diseases related to the heart or cardiovascular system. Oncologists focus on treating cancers wherever they might be in the body. Palliative care specialists focus not on any one organ system or one disease. We focus on treating patients with very serious and complex illness. That serious or complex illness might be, in some cases, cancer. It might be advanced and complex heart or lung disease, or it might be advanced Parkinson's or ALS, for some examples. Palliative care focuses on providing relief from the symptoms and stress caused by their serious illness or caused by the treatments for their serious illness. The goal of palliative care is to improve the quality of life for the patient and the family. As a palliative care specialist, some of my patients do achieve cure. Some of my patients live many months or years longer than originally expected, but they're living a very good quality of life, but eventually do succumb to their illness. And some of my patients are living with an incurable illness, yet they're living a reasonably good quality of life. And some of my patients have even told me that their quality of life is actually better than before their diagnosis. How can this be? Some people will say to me or ask, palliative care, isn't that basically pre-hospice care? And my response to that is palliative care is no more pre-hospice care than cardiology or oncology, for example, are pre-hospice care. And what I mean by that is that cardiologists and oncologists focus on treating patients who have a serious illness. Some of those patients might be able to be cured or do achieve cure. And many of those patients will live many, many months or many, many years while having their disease managed, hopefully their symptoms improved. But eventually, the patient will succumb to their illness, and at some point, they'll transition to hospice care because that will best serve their needs. So in that way, palliative care is no more pre-hospice care than a lot of other medical subspecialties. Palliative care is not the same as hospice care. Part of the reason why I'm talking about palliative care and hospice care is in part to provide some education and understanding on the distinction and difference between hospice and palliative care. But for the purposes of this talk, and more importantly, is to give you a sense of, with what I do, the wide spectrum of patients and very serious situations that I deal with on a regular basis. A lot of us talk about a good death or what constitutes a good death. And much has been written about what is a good death and maybe what isn't a good death. A lot of studies have actually been done looking at various variables or surveys on what people, medical professionals, patients, or caregivers, believe constitutes a good death. Of course, what constitutes a good death is going to be subjective and dependent on an individual's values, personal preferences, and perhaps even culture. In 1997, the Institute of Medicine stated that a good death is one that is free from avoidable distress and suffering for the patient, family, and caregivers, in general accord with the patient's and family's wishes, and reasonably consistent with clinical, cultural, and ethical standards. The literature and various surveys have been studied and teased out, looking at all the different variables that people claim contribute to a good death. These are some of the factors that are commonly raised as identified what many patients or caregivers or medical professionals identify as contributing to a good death. That is personal preferences for the dying process, what the patient hopes that looks like and where they hope to be, being free of pain and suffering, maintaining a sense of emotional well-being, maintaining a sense of dignity, and having the presence of family in their final days, weeks, or months of life. We can't all choose or control exactly what we will die from or where we will be when that time comes. But there's a lot that we can do if we face death, think about it thoughtfully, where we can choose a journey filled with a greater sense of peace, dignity, and harmony for our end of life, for whenever that time may come, as opposed to a course or journey that is fraught with more distress, more potential suffering, and fraught with the chaos of the medical system and interventions that are probably non-beneficial. Some of my physician colleagues have approached me personally or privately and have sometimes asked me, with what you do and with what you see and the wide spectrum of what you see on a daily and regular basis, what disease is the worst? Which one causes the most suffering? Is it ALS and becoming progressively weaker, losing your independence and feeling trapped in your debilitated body? Is it head and neck cancer or cancer of the esophagus and dealing with the pain that comes with it, or difficulty swallowing, or the deformities that the cancer or sometimes the treatment itself may bring with it? Or is it advanced lung disease like emphysema and feeling like you can't breathe and you're struggling to breathe and feel like you're suffocating? My response to my colleagues when I'm faced with that question is the following. There is no disease or illness that correlates well with a good and easier journey and end of life, or more or less suffering. There is, however, a characteristic that I've come to see time and time again that does correlate with whether a patient is going to experience a good death or a more difficult, tumultuous end-of-life experience. And that characteristic is the following. How well aligned a patient's expectations are with the reality of their situation. When a patient's expectations are poorly aligned with and discordant from the reality of their situation and circumstances, these patients tend to experience much more disappointment, distress, suffering, not just during their treatment course, but also at the end of life. When a patient's expectations and reality are more appropriately aligned, these are the patients who tend to have an easier and calmer course throughout their treatment and experience less distress and suffering when their end of life comes. In fact, it's gotten to the point where I can actually predict early on who is going to have an easier and better end of life experience and who's going to have a more difficult journey in their end of life. And again, it all comes down to this characteristic. That characteristic, again, is how well aligned one's expectations are with the reality of their situation and circumstances. In my work as a palliative care physician and as a hospice care physician, one thing that I've come to see is that people oftentimes die much the way they've lived. If someone has lived a life full of anxiety, unnecessary pain, and chaos in their life, their end of life is probably going to be fraught with anxiety, unnecessary pain, and chaos in their life. When they've had a life where their families cause a lot of drama or distress or discord, they're probably going to have that same kind of unfortunate chaos and discord with family near the end of their life. On the other hand, when patients go through their lives with good coping skills, a mature sense of how to go about things, and have a good sense of how to deal with difficult circumstances, these patients tend to have a calmer and easier and well-adjusted experience at the end of their life. So how you live oftentimes is how you die. And changing how we live can be difficult. And while that may be true, thinking about thoughtfully death and dying and what matters most to you can influence and change how you live today. This all comes down to this concept, and I'm here to tell you today that there is a different way of approaching this. Change your death, change your life. In the last 10 plus years, a lot of studies have been done looking at the effects of palliative medicine on patients living with a serious illness, and specifically looking at the involvement of early involvement of palliative care, even as early as the time of diagnosis. And these studies over the last decade or so have shown repeating themes, and what we've learned from these studies is that patients who are facing a serious illness and have a palliative care specialty team involved in their care experience and report a better overall quality of life, less rates and less severity of depression. They tend to have a better and more accurate understanding of their illness. They tend to report a more accurate understanding of their prognosis. And what these studies have shown is that the patients who have the benefit of a palliative care team overall live just as long, and in some studies we've learned that they live significantly longer than the patients who don't have a palliative care team involved in their care. And this is also true of their caregivers and families. Studies have looked at the effects on caregivers and families, and what we've seen is that families experience less depression, they cope better with the circumstances, they have better bereavement support, and report an overall better experience. So what is it about palliative care that's resulting in these changes and these benefits? Palliative care certainly does do a lot to try and help the quality of life of patients. We have physicians that are expertly trained in meticulously managing complex symptoms. We have social workers dedicated to our team to help patients and their families navigating the medical system and helping with additional resources. We have psychotherapists dedicated to these patients to help them with coping with their serious illness and empowering them with tools to deal with their symptoms and their journey. But what I think contributes more than anything to these benefits is communication and honesty. Eloquent and expert communication and forthcoming honesty about their illness, about their prognosis, about their treatment options, about the intentions of their treatment options, and the likely outcomes. The other thing that we do as palliative care specialists is we engage our patients in thinking about what matters most to them, and we engage them in difficult but valuable discussions about end of life. Not because they're dying now or they're going to die soon, but by talking about end of life, we can have a plan in place so that way they feel reassured that whatever happens in the future, there's a plan, there's something we can do. There's something we can do to help them and to help them continue living as well as they can. I'm going to tell you about a situation and scenario that I encounter frequently in the hospital setting. I'm consulted and being asked to see a patient and to help this patient delineate their goals of care. This patient is clearly in their final weeks or perhaps months of life, and because of that, they're weaker than they usually were, and they also get more fatigued more easily. And this patient is now faced with a choice, depending on their circumstance. In one scenario, they're faced with the choice of, you're pretty weak here in the hospital, but we can offer you a course of subacute rehabilitation in a skilled nursing facility for several weeks to try and maybe possibly get a little bit stronger. Or you can focus on your comfort, your quality of life, and returning home with a hospice care team to help support you. In another patient, it might be the option of continue with a couple extra attempts at third-line chemotherapy, or return home focusing on your comfort, your quality of life, and going home with the support of a hospice care team. And I'm being asked to help this patient to make the best possible decision for themselves in this difficult circumstance. And I take the time to get to know who this patient is, what matters most to them, what is important to them now and in the future, and what their personal values are. And as I get to know them and talk with them, one patient might be telling me, I want to pursue that course of subacute rehab because I'm a fighter and I'm not going to give up. The other patient might tell me that she wants to pursue that extra chemotherapy because she's not quite ready for hospice care just yet. And as they tell me more about what they're looking for and what they're hoping for, it becomes more evident to me as I'm listening to them that their hopes and their wishes and their expectations can probably be best served and supported by hospice care. And so in these situations, I'm oftentimes asking these patients the following. We can't predict everything. We can't predict how chemotherapy will go, another trial of chemotherapy, or how a couple of weeks at a rehab facility will go for you and what benefits you might get. But we do know a couple things are certain and true. What we do know is that your time is limited and your energy is limited. We don't know exactly to what extent your time is limited, but we know conceptually it's limited. And the patient can often tell me better that to what extent their energy is limited and how easily they become weak and disabled. And so I oftentimes ask them, knowing that your time and your energy are limited, how do you most want to spend your precious limited time and energy? If you take the time to think thoughtfully about how you most want to spend that time and energy, do you want to spend that time a couple of weeks at a skilled nursing facility doing some rehabilitation, where physical therapists and occupational therapists will consume your precious limited energy? Or do you want to go home and spend your time with your family and spending your energy doing things that are more important to you? By thinking about and answering what's most important to you and how you want to spend your time and energy, the answer to that will probably serve as a good guide to how to make your decision. Precious time and energy is not unique to patients facing their final chapters of life. It is true for all of us. We all have limited time and limited energy every day. And so I ask you, how do you most want to spend your precious limited time and energy? By taking the time to think and imagine your end of life and how you most want that to look and how you most want to spend your precious limited time and energy, that can inform how you'll live today. And by taking the time to think about how you want to live today, it can inform how you probably will die. If you take this information and what I told you earlier, that I can predict who's going to have an easier end of life, who's going to suffer more, or who's going to have a calmer end of life, and that how one lives informs how one is likely to die, what changes will you make in thinking thoughtfully about your death, and how will that inform how you live today, and how will it influence your loved ones today and at the end? By taking the time to think about changing your death, you can change your life. And by changing the way you live, you will inevitably influence how you will die. Thank you very much.